Session fourth session in the series of the psychotherapy process sessions. It should be 04 and not 03. We'll focus today on diagnosis. We started the psychotherapy process and we said there are 7 steps of the psychotherapy process. Step 1, case history. Step 2, psychological testing. Step 3, diagnosis. Step 4, pathogenesis. Step 5, treatment plan or therapy. Step 6, supervision. Step 7, termination. And the first session we did was on overview. So 7 sessions on 7 parts of the psychotherapy process and 1 session on overview. 8 sessions on this whole process. So let me just correct it. So today we'll focus on the third step of the psychotherapy process, diagnosis. Diagnosis is the third step of the psychotherapy process. Based upon the information we get from the case history and from psychological testing, if necessary, we arrive at a diagnosis. Diagnosis meaning, based upon the characteristics of the problem, what is the name that we give to the problem? And to give the name, we use DSM-5 or ICD. DSM-5 is the Diagnostic and Statistical Manual Edition 5, popularized by American Psychiatric Association and used in America, USA. Whereas ICD is a WHO document, International Classification of Diseases, and that has classification of both biological problems and psychological problems, and the psychological part can be used for diagnosis. In India, in USA, and many countries, DSM-5 is more popular. Some countries also mandate by law whether you can use DSM-5 or ICD, or you can use either of them. In India, DSM-5 is more popular. So, for example, if somebody says he feels low mood, bouts of anger, feels like avoiding people, doesn't feel interest in any pleasurable activities, then based upon these descriptions, we will go to DSM-5 and find out what is the name of the problem where these are the characteristics of the problem. And then we'll realize the person is suffering from something that we call depression, where these are the criteria. So DSM-5 will give criteria that out of these 9 criteria, if 5 are met, you can call the person suffering from X. So for every sickness, there will be a set of criteria and a minimum qualifying number that the person must meet in order to be diagnosed with that particular disorder. So diagnosis is based upon the information we have from case history and psychological testing, and we reference that information to DSM-5 or ICD and arrive at a diagnosis. This is a psychiatric diagnosis, but now this is used by therapists also. The therapists also use now the same language as the psychiatrists do, so there is a bridge between the two and there is a commonality of language. This was also necessary because psychotherapy as an area had too many schools inside of it, and every school has its own way of diagnosing and generating pathogenesis. So if we leave it to each school, every school of psychoanalysis and every school of psychotherapy in the Western world, and now those things are global, each school has its own way of diagnosis and pathogenesis. And then there would be no common language to communicate in. So it's a very good element that as a language of communication and as a consensus language, everyone, therapists and psychiatrists both today, use DSM-5 or ICD, DSM-5 more than ICD, for diagnosis and communication with each other. So we diagnose using DSM-5 and ICD. However, after doing that, in addition to it, if we want, and only if we want, we can do a psychoanalytic diagnosis which would have a different color and flavor than DSM-5 or ICD. For example, if you are a follower of a Freudian school, and if you believe that out of 22 chapters of DSM, 4 chapters are largely biologically driven, whereas 18 chapters have a strong psychological component, then for those 18 chapters, if each chapter has, for example, 7 sicknesses listed out on an average, then you would come to something like around 126 sicknesses. And if you are a Freudian and if you believe that all problems originate in oral phase, anal phase or phallic phase, then if you take 5 things that can go wrong in the oral phase, 5 things in the anal phase, and 2 things in the, say 3 things in the oral phase, 5 things in the anal phase and 2 things in the phallic phase, you come to 7 to 10 basic Freudian concepts which explain pathology. So this 125 or 126 sicknesses in terms of causation have to collapse into those 5 or 7 elements only. If you are practicing CBT and if you believe there are 3 core problems, then 18 chapters of DSM in terms of causality have to collapse into ultimately those 3 things only. So if you were to create a DSM of Freudian school or DSM of CBT, it would be very different from the DSM of psychiatry. Which approach is better? That is a different question. Someday we will discuss it when we go into details of DSM and details of various options we have in diagnostic frameworks. Some other time we will discuss. Today we will just focus upon the fact that diagnosis is done using DSM-5 or ICD, more often DSM-5, using the information from case history and psychological testing, the first 2 parts of the psychotherapy process, and referencing it to DSM-5 or ICD. So diagnosis is the 3rd step in the psychotherapy process of arriving at a diagnosis of the problem the person is suffering from, giving it a name. In addition to the name that we get from DSM-5 or ICD, we can also do psychoanalytic diagnosis and psychoanalytic pathogenesis of the situation based upon our school. So let us say we are talking about a problem, the person is afraid of somebody attacking him. DSM-5 and ICD would say the person is suffering from paranoia, delusion of persecution. Let us say if he is suffering from delusion of persecution, then the Freudian and the Kleinian description of it will be very different. So in Freudian terms, essentially the problem would be of repressed homosexuality, and in Kleinian terms the problem would be of an open split. So the diagnosis and pathogenesis in Freudian and Kleinian schools are different, but if we want, in addition to DSM-5 and ICD, we can do for our own satisfaction or our own necessity second diagnosis and pathogenesis based upon the school we come from, or if we are knowledgeable in more than one school, we can do a consolidated psychoanalytic diagnosis and pathogenesis based upon the situation. Take an example. The Lacanian framework of diagnosis is very different. So if we look at the Lacanian school of psychoanalysis, the Lacanian diagnosis would be to classify all problems into three: neurosis, psychosis, and perversion, which is very different from the Freudian scheme of diagnosis, or Kleinian school of diagnosis, or OSHO school of diagnosis. So every school in psychoanalysis would have its own way of diagnosing certain things, and also its own way of developing a pathogenesis of a given. A Jungian diagnosis also will be radically different from the Lacanian, Freudian, or Kleinian, or Kohutian. So DSM-5 in a way has globally won, because DSM-5, the good part is it is theoretical. It does not subscribe to any school, be it a psychotherapy school or a psychiatry school. It just is a descriptive document which is theoretical and based upon clinical experience. So in diagnosis, the fundamental principle we remember is we do DSM-5 or ICD if that is the case, and then go to our psychotherapy school and complement it and not substitute it. Complement the diagnosis of DSM-5 or ICD, not substitute the diagnosis of DSM-5 or ICD. So this is the third step of the psychotherapy process. After case history and psychological testing, we come to diagnosis. And after diagnosis, we go to pathogenesis, details of which we will discuss in the next session. Any questions? Write to me at hvindia@gmail.com. Thank you for being with me in the session.